So, hi everyone. My name is Lisa Morad McCoy. I am a therapist at the UNM School Based Health Center, and I'm excited about doing this presentation for all of you today. We're going to be talking about depression and suicide in adolescents. So this is kind of a summary of what we're going to do. We're going to talk about statistics, some signs and symptoms, assessment of depression, which is really the bulk of the presentation, some treatment techniques, and then at the end, some resources. And I have a bunch of handouts that should be uploaded to this presentation. I'm not going to have them on the PowerPoint itself, but just they are not in any particular order. They talk a lot about treatment options and some of the assessment tools that I use. Okay, so here's some statistics. These are from the New Mexico Department of Health. It was from their 2015 mental health report, and they're actually stats from 2013. So the first one is youth who have made a plan in the last 12 months to, basically it's suicidal ideation. So nothing actually happened, it's a plan. And so it's about similar in the US and in New Mexico, 13.6 and 13.7, so we're right on target there. Youth who attempted suicide, in the US, 8% were a little higher, and this is again 2013. So this is youth who completed suicide, and it's per 100,000 youth ages 10 to 24 from 2009 to 2013. So it's a pretty big sample size. And it's ages 10 to 24, so it's a little bit out of our age range for this presentation on both sides, but I still think it's relevant. And as you can see, New Mexico is pretty high. The US is significantly less, but basically what these stats show is that suicide among youth is extremely important, and it's also the second leading cause of death in New Mexico and in the US for youth between the ages of 10 and 24. So some of you probably already know a lot of this, but girls tend to attempt suicide more often, and boys actually are more likely to complete suicide. And one of the reasons for that, and we'll talk about this a little bit later, but one of the reasons for that is that boys tend to use more lethal means. And so when they are ready to do something, unfortunately, they tend to use means that are more accurate, for lack of a better word. So if you have a boy in treatment who is displaying signs of suicide or having suicidal ideation, it's very important to just watch those signs and symptoms. Girls too, obviously, but girls tend to do things that are a little bit less lethal. So some other factors that you have to consider in terms of youth suicide are, is there a history of substance abuse? Is there a history of suicide within the family? So if a kid comes to you and they have a history of suicide in their family, like their father or their parent or a brother has actually committed suicide in the past, that is actually a risk factor for that youth. And also obviously stressful life events and access to, this says firearms, but I'm going to just say access to any lethal weapon, including medications that are around the house. Okay. So I just put this slide up there because it is basically the source. And my intern Marissa actually gathered all of this information for me. So shout out to her. She's a NMHU student in the social work program this year. And so it's the New Mexico Department of Health, and it's from the New Mexico Regional Mental tired. In teens, you see a lot of social withdrawal where they used to be really social, and then maybe there's a break in that and they don't socialize as much. Hopelessness, we'll talk a little bit more about that later. And then change in habits, eating and sleeping. So if you're seeing changes in teens, that's what you really want to pay attention to, because teens can look different. Depression looks very different in teens at times. And because a teen isn't necessarily going to come up to you and say, I have chronic depression, or, I think I've been depressed for 5 years. They don't have the development to really understand time in the way that adults do. So these are some signs and expressions that I hear from teens every day. I work in a school-based health center, and I see kids every day for therapy. They get referred to me for all kinds of reasons, but I would say one of the underlying reasons most often is depression. So I kind of listed some of the things that I hear. Nothing is fun anymore, or I just don't care. They start to quit activities. So, for example, I had this one youth who was really excited about basketball, and that was what they did for extracurricular activities every day, and then they just slowly quit, and it was a slow quitting over time. This person just eventually stopped going to practice and didn't play anymore. And it was kind of sad to see, because this person was a really great athlete and was really important for the team. So, and then they say things like, I just want to sleep. Okay, so, and that may seem like a kind of innocuous statement, but really, if they're saying that every day and they're taking these long naps after school, so at the school I'm at, it ends at about 2:30. That's pretty early in the day. And so what these kids will do is go home and get home from school, maybe have a snack, and then go to sleep. And then they don't wake up until, it's time to eat again. And then they might eat something, but then go back to sleep. So they're using sleep as a way to escape from their feelings. And so like I said initially, it may seem pretty innocuous, but it's an important symptom to look at with teens. So also them saying, I can't sleep. So maybe they're taking a long nap after school, but then at night they can't fall asleep, and they might be on their phone, or they might just be pacing around the room. I have one kid in high school who was doing that in the middle of the night, just kind of pacing around and trying to figure out ways to get to sleep. So other things are complaints from teachers about behavior. Maybe the kid is falling asleep in the middle of class. Maybe they're just kind of zoning out. And maybe there's a big drop in grades. Maybe they had really pretty good grades, and then there's a significant drop. So those are all things to watch out for. So symptoms of suicidal ideation, basically. So what you see with suicidal ideation in adolescents is you see all of the symptoms or some of the symptoms of depression that we talked about before, including this preoccupation with death and dying. Um, and there's a significant low self-esteem. So these are the kids who they just basically don't look like they have much hope anymore. They come in and they kind of sit there. I have this one child that I'm working with who in the beginning of the year would just come in and sit, and really, like, you could tell that she didn't have enough energy to even talk. And so a lot of these kids won't have energy to talk in therapy even. So, and then there's decreased protective factors, and we're going to talk about protective factors in a little bit. But, basically protective factors are some sort of support network that that they can rely on. And then the other symptom and sign that you see with suicidal adolescents is this isolation factor. So they're just kind of not interacting with anyone, friends, family. They're kind of really isolated. So when you have the symptoms of depression and these symptoms together, that's a pretty high, you want to watch that kid and make sure that there's some resources that you can point them to. Okay, so these are some of the expressions that I've heard from suicidal adolescents. So I don't want to be here anymore. So they don't say, Miss, I'm suicidal, I'm going to kill myself today, or they're not that specific. It's all very subtle. And so in many ways, you have to really listen to their language. So some of the stuff I've seen is, I'm done. My friends and family are better off without me. A lot of kids are listening to a lot of music and videos about suicide. And so asking them things like, what do you do? So you're in your room and you're sad and you're feeling alone. Are you doing anything? If they say, oh, well, I listen to my phone or I'm watching videos, what do you watch videos of? Ask them. Because 9 times out of 10, if you're asking in a non-judgmental way and your tone is good, they're going to tell you. And I've actually sat and looked at some of these videos with kids of what they're listening to, and it may not be something super dramatic, but it might be somebody reciting a poem about suicide, for example. And then these last ones are really serious. So if you see a kid giving things away, a sudden burst of energy following severe signs of depression, and writing out about a plan or images of a funeral, those are all really high risk behaviors. Because, right, if they're giving things away, they're making plans. And then a sudden burst of energy following severe signs of depression usually means that they have made a decision and they're comfortable with their decision, and it's a sense of relief. And that's where the energy comes from. I have to say, this is pretty rare. I have not seen something this drastic in the time that I've been working in the school-based health center. I've seen little snippets of it, but never this severe. I just want to really caution that if these things are going on, it's a very high-risk situation. Okay. So assessment of depression. It's important when you do assessment, and I'm not sure how far along you guys are with assessment skills, but to really understand and kind of be a detective about their symptoms. And with teens, you have to be sometimes you have to be pretty concrete. So when I'm saying when, how long, and asking about time, essentially, these questions really have to be teen friendly, because if you ask them something like, How long have you felt this way, or have you felt this way for 2 weeks? A lot of them don't really understand time in the way that we think they do. Okay, so this is kind of what you're looking for when we talk about teens and their context of time. So put time in context. Use age, grade, common life events. So not necessarily have you felt this way for 2 weeks, but have you felt this way since elementary school? Have you felt this way since Christmas? Since whatever holiday they celebrate? Have you felt this way since winter break? So it really gives them context, and then it gives you context in terms of, okay, so this has been 6 months, 2 weeks, 5 years, whatever, and then give examples of thoughts, feelings, and behaviors. So you can tell them stuff like, have you been thinking like, I don't I don't want to do anything today. I feel like I can't do anything today. I feel stupid. I don't like myself. I'm ugly. Those are all thoughts that go along with feelings of depression. So feelings, sadness, anger. And I have to say, a lot of people tend to minimize anger. A lot of teens, both boys and girls, express these feelings in anger. They don't necessarily, you're not going to necessarily see them crying. But so just don't dismiss anger if you see it. Okay, so here's some little do's and don'ts. So the big don't is giving some really specific clinical time construct. So have you been feeling this way for more than 2 weeks? A teen is not going to be able to give you an accurate answer. Have you been feeling, doing, thinking this way since all of these things like I talked about before? School started, winter break, middle school, elementary school, homecoming, prom, your brother or sister was born. That way it gives them context, and again, it gives you some sense of how long this has been going on. And for example, has it been since your brother or sister was born? That's pretty simplistic, but it can give you an idea, well, maybe it's the brother or sister that was born that maybe triggered some of these feelings. And then you can get into some family dynamics that way. So the important thing with assessing teens is don't be in a rush. Really try to find out how long they've been feeling this way, and just, weave it in and out of some other conversation at times, because you don't want them to feel like you're interrogating them. But I usually have pretty good success when I use context like this. Okay, some more do's and don'ts. Have you been feeling irritable or having feelings of hopelessness? So give them context again. Have you been in a fight or argument with a friend since school started? How about with your family? So you're giving them context. Have you ever thought to yourself, I don't care about school anymore? Is there anything else that you felt that way about? So they may say, yeah, I feel that way every day. I don't care about school, and I don't care about, I used to love going on hikes after school, and I don't like that anymore. Or I used to love playing baseball, or I used to love drama, and I don't like that. So it'll give you an understanding of, wow, this kid used to be pretty active and involved, and now they're not anymore. Okay, so ask about internal and external environments. And I will explain this more, but internal environments are basically the mind, and external environments are what the kid is going through, what they're experiencing in the outside world. Okay. So internal environment occurs within the mind again. So this is thinking of self. And so the reason why I have these two different categories is because really when you're talking about cognitive distortions, which is a belief system that is not necessarily rational or true, but that you're thinking about yourself in that way, people usually tend to think of themselves as unlovable, some form of unlovable or incompetent. And if you can think about that in those terms, I think it makes those cognitive distortions a lot easier. So asking them about how do they feel about themselves? How do they feel about what they do and what they can do? And then their perception of their protective factors. So what's their perception of their support system? What's their perception of how their parents feel about them or caretakers? What's their perception of what they look like? Of how good they are at things like that. And then, of course, feelings, sad, nervous, afraid, angry. You would be surprised at how difficult it can be for some teens to actually name their feelings. They might say, I'm upset or I'm frustrated. And one thing that I really try to get them to do is to name their feelings and to understand, okay, that's sad, that's afraid, that's angry. Because sometimes when you can learn how to talk about this stuff, it can start to feel better. Okay. So external environment. This is the world the teen lives in. Family, friends, school, protective factors. And that's all really important to ask about family, to ask about friends, school, and protective factors. I have all of that in my assessment that I do of teens, of every teen, and you can get a sense of how their life is going when you ask these questions. Okay, so a little Calvin and Hobbes there. I put this up because it's so important when you're working with teenagers to have some type of collateral from family. I know that these days, and it's a wonderful law that teens can seek behavioral health at age 14 and up without parental consent. But for those kids who are willing to have you talk to their family, it can be really helpful because you're only seeing their perception of themselves if you're just talking to them. If you talk to a parent, you're seeing the parent's perception, and it can really clarify some of the things that are going on. And later on down the line, you might be able to work with some of the disconnection that they're feeling with their family. Because I would say 7 out of 10 times, depression tends to have its roots in family and in just family interactions and how connected they feel to their family. So that's why I put here, get family input, collateral whenever possible. Social work, this is a social work program, is based on person and environment. So if you're just seeing a person in the office every day and not necessarily getting an understanding of what their environment is like, you're just not getting the whole picture. So, and when I say family, I mean any family. So if they don't live with their parents, that's fine. It doesn't have to be a legal guardian. It can be a sibling. It can be anyone, as long as it's okay with the kid. And usually the way I frame it is to say something like, look, you know, it would really help me to understand what you're going through if I can talk to someone in your family. Is there anybody in your family or who takes care of you that I can talk to? And you'd be surprised how many kids are really pretty open to that, because part of it is that they want to be able to, they want to be understood. And they want to be able to give some of that over, some of their feelings over to somebody else and just have someone else take care of it for a while. And that can really help. The family sessions that I have had, I have to say, it only takes one or two, and then maybe one or two phone conversations for a family to say, oh yeah, my daughter is really struggling right now and I'm going to step up for her. Because a lot of times caretakers don't know. They're in the dark about how their kids feel. So, okay. So some of the assessment tools that I use, I have the PHQ-9 as a handout for you that should be uploaded. I don't have the GAD and the SCARED. They're a little longer. Well, not the GAD, but the SCARED is longer. So the PHQ-9 is this 9-question screener for depression. And it has a severity scale, and it's a very simple questionnaire. I really like it for teenagers. And it's actually the one that you're supposed to use for teens is the PHQ-9A for adolescents and youth, and that's the one that I have on the handout. It's worded a little differently for teens. And the GAD is to test for anxiety, and it's a shorter version of the SCARED. The SCARED is to screen for anxiety too. I like the SCARED better because it gives more information. So if you have time to use the SCARED, I think it's a better tool. So the reason why these assessment tools are important, I think, apart from just giving you an understanding of where the kid is that they can be used as teaching tools with the kid. Kids are so interested in the scoring of these questionnaires. And when I first started using them, I was amazed at how interested they were. And because it gives them a name for what they're going through. And so some teens are really concrete. So if they can see on a questionnaire, oh yeah, my depression is moderately severe, or I have mild depression, or I have, I'm kind of struggling with moderate anxiety, and they can see that on paper, it's very informative for them. So I go over all the scoring with them and help them understand, this is a thing. You're not crazy. This isn't out of left field. Other people feel this too. And that's the other part of working with teens, is really normalizing their feelings, normalizing their thoughts, and helping them understand that this doesn't have to be permanent. Okay, so assessing suicidality. And this is often a very anxiety-provoking area for a lot of clinicians. But over time, I think you can get a feel for when a kid is really high risk and when they're not. It just takes practice, and it just takes seeing a lot of different people. So basically, what you want to know is there a plan? What is it, and how detailed? And really, get them down to the nitty-gritty. If they are very suicidal and they're going through suicidal ideation, you really want to know, what is their plan? Do they have times figured out? Do they have transportation figured out? For example, when they get off the bus at the end of the day, what are they going to do? Is anybody going to be home? Where is the means to carry out the plan? So do they have pills? Where are they? So, and the reason you're getting this information is because you want to see how clear they are. So if you're getting a lot of I don't know answers, and I don't know, I just thought I would find them somewhere, that to me is a sign that this child is not as suicidal as they're saying they are. They don't have a completed plan in their mind. If they're giving you time, if they're giving you um, details, then yeah, I would be really careful about assessing them. Um, and then, do they suddenly have energy again following a significant bout of depression? This is pretty important. If you have this depressed kid who's coming in like that Eeyore picture that I showed earlier, just kind of down in the dumps, and then they come in and they have this burst of energy, really try and assess that. And then again, are there protective factors? So my next slide is protective factors, and we'll talk about that. But there is a suicide scale. It's called the Columbia Suicide Assessment Scale. I didn't put it in the handouts, but you can look it up if you want to. It's a pretty good assessment tool. The problem is that what we know about some of these assessment tools with suicidality is that the actual tools are not a great assessor or a great predictor, I should say, of actual suicide attempts and completed suicide, because especially for teens, in a moment of crisis, they feel terrible and they feel suicidal, and so they're answering that questionnaire based on a moment and how they feel, and then their feelings change over time, and they don't, and they're fine an hour later. So this is the other issue about assessing suicidal teens, is that quite often time will settle them down. So I've had kids who I bring into the office, they're very suicidal. I work with the family, send them to the hospital, and all of this has taken probably about 4 or 5 hours. Well, by the time they actually see someone at the hospital and get evaluated to be admitted, they're like, forget this. I'm not suicidal, and I'm never going to be suicidal again. I don't mean to be flip about it, but that is how changeable the teen brain is. Okay, so sometimes time and a snack will help them de-escalate from this. Okay, so protective factors. If you have a kid who's future oriented, that is a really good sign. If you have a kid, for example, who's saying, yeah, I really want to kill myself, but if I do, then I'm not going to be able to go to college. I'm not going to be able to have a family. That's a really good sign, and often a predictor that they are not suicidal, and that this is something that's going to pass. So family and friends to care for. One question that I ask them is, when you're feeling this way, when you're feeling like you want to die, who do you think about? And quite often it's like, well, I think about my little brother, or I think about my mom or my dad, or I think about somebody who has died and think that somehow they wouldn't want me to do this. So, and then also a history of resilience. So there's a lot of kids out there who are very resilient and resourceful. And if they have a history of that, and you can point that out to them, usually that's a really good sign. And then again, supportive caretakers. So assessing protective factors can be really helpful. I really, sometimes that's overlooked when assessing for depression and suicide, but these protective factors are something that you can really tap into. Okay, so treatment. So techniques are helpful, but really, and what the students who I've had in the past hate it when I say this, but it really is all about the relationship. I think as a student, there's always something really comforting about having a technique under your belt. And I felt that way as a student, but if you don't have trust with this person, if you don't have a relationship with this person, you can try any technique in the book and it's really not going to help that much. And there's articles that talk about the fact that non-specific factors in counseling and in therapy, which is basically the factors attributed to the therapist and to the client themselves, those non-specific factors are the most helpful part of treatment and therapy. So I put an article about non-specific factors. It's a long article, but I encourage you to read it when you have some time. It's a really great article for people, I think, who are starting in this field. Okay, so, but we will talk about some techniques because I do think some techniques are very helpful once you have that relationship established. So cognitive behavioral therapy. This is a very tried and true old technique of connecting your thoughts, your behaviors, and your feelings. And so with teens, the important thing here is to not get too complicated with it. Cognitive behavioral therapy can be complicated. But what you want to get them to learn is to connect their thoughts with their feeling and then with their behaviors. Many of them, I would say 90% of them don't know how to do that. Sometimes adults don't know how to do this. And so the way you do this is you get them to recognize, oh, I'm having a thought, that this is a thought that occurs a lot in my mind, like, I'm ugly. Okay, so if this person is thinking, I'm ugly over and over again, how are they going to feel? Not so great. So they feel down. And what's your behavior? Well, if I'm ugly and I don't feel good about myself, then I'm just going to stay home instead of going out with friends. So that's very simple, but you can teach teens how to do this and realize that they actually do have some control over their mind. Not complete control, and you want to be careful with teens who are perfectionists, because if they feel like they can't do this, then they get super frustrated. So you just couch it by saying, you're not gonna be able to do this right away. It's gonna take practice. It's like going to the gym. The more you do it, the better you're gonna get at it. They never believe me, but okay. So dialectical behavioral therapy. This is sort of my personal favorite. I love DBT because it really helps kids especially learn how to regulate their emotions. And it's based on coming back into the now, into the present moment. And it's the dialectical behavioral part is the idea that I'm going to accept myself for who I am and realize some of the things that could change. So you're accepting your present moment and you're saying, yeah, there's some things that I need to work on. Instead of this very black and white, the world is awful, I'm awful, I don't feel good. That's not a good place to start. So you get them accepting, yeah, I feel awful most of the time, and I'm going to see if I can work on feeling better. And so how do you do that? These are the basic 4 components of dialectical behavioral therapy. Mindfulness, which is being aware of your present moment, being involved, being in the now, and not 5 years from now, not 10 years ago or 5 years ago, but right now. Emotional regulation, so understanding the fact that you can regulate your emotions and that there's ways to do that. Distress tolerance is just trying to get through something that is stressful by accepting it and not making things worse. So these are all kind of complicated concepts for some teens. There's tons of exercises out there. I have a couple handouts uploaded, but try to look into DBT when you can, or get a training, because it's very interesting and very helpful for teens, and it can be fun too. And I think it's more interesting in many ways for teens than just straight CBT. Okay, so mindfulness is a huge component of DBT, is paying attention and intentionally paying attention and on purpose to the present moment. But here's the kicker: non-judgmentally. Okay, if they have a judgment, they have a voice of judgment in their head, then it's going to be really hard to get better. So really getting into that space, and really, you know, as therapists, if we're going to help these kids get into that space, we need to be in that space ourselves. So doing our own DBT can be really helpful too. So here are some resources. These are all hotlines, and these are all 24-hour hotlines for kids and adults who need help. I debated putting some resources for LGBTQ youth, but I have a feeling that you're going to have another talk on that, so I don't want to step on that. But there are resources for LGBTQ youth specifically, which, you know, I didn't talk about that very much in this presentation, but they tend to be one of the biggest, you know, one of the highest risk groups for depression, anxiety, and suicidal ideation. But so I think, you know, when you do have a talk on LGBTQ, keep that in mind, because it's a really important population to talk about. So that being said, this is pretty much the end of this presentation. If you have any questions, you know, let us know. And please, there's tons of resources out there. So if you're doing work with teenagers, also realize that you're not alone in doing it, and that you can, there's always ways to ask for help. And thanks for listening today.
Okay.